Okay, you guys will probably have to hit the little consent thing. Let me share my screen here. Okay, can you guys see that? Okay. Can you guys see the PowerPoint now? Yeah? Okay. Okay, so we'll start with GU conditions, okay? Here are your objectives. You guys are more than capable of reading those, so I'll let you read those. Okay, so different assessment techniques for urinary function. There's different diagnostic procedures. Obviously, one of your first things you're going to do for assessing urinary dysfunction is a UA. Okay, so collect that urine. They a lot of times end up getting ultrasounds if they're having, you know, bladder intensity or frequency, and the UA is negative, then a lot of times the next step is an ultrasound. If there's concern of like an infection in the kidneys, like pyelonephritis or something like that, then a lot of times they go ahead and they do the pyelogram. And then CT of kidneys. X-rays and things like that aren't helpful with GU conditions. And then they'll do a voiding. So VCUG, I don't know if any of you guys work in healthcare right now as CNAs or what have you, but that's probably the most common test that they do. So that is, they actually have a little camera and they have those patients urinate while the camera is inserted, and they're able to kind of assess the flow. Okay. Okay, so dysuria. Dysuria is discomfort with urination. Okay, that's how I have always remembered it. Discomfort. Okay, so that's going to be your burning and your discomfort with urination. Frequency, obviously, that means you have the sensation you have to go all the time. You feel like you always have to go to the bathroom. That's frequency. Urgency is like the second you get that sensation, you have to go to urinate. Okay. Nocturia, that's urinating at night. So like awakening at night to urinate. Enuresis, that's having urinary accidents at night. That's actually really, really fairly common in kids, even up to adolescent age kids sometimes. Polyuria means you're peeing a lot and constantly. So like that frequency. Okay. And oliguria means you're feeling like you have to go pee, but you like can't get all your pee out. Okay. Come on. Okay. So phimosis. So that is when the foreskin comes over the prepuce. So instead of being retracted, it becomes really tight and narrow, and you can't retract the foreskin back over the penis. So the way that they fix this, they actually have to go in and circumcise these kids. Sometimes parents will try to really pull back really hard or forcefully pull back, and that can almost cause more damage. It's called paraphimosis. So then it's like worsening inflammation and worsening tightening of the skin, and it'll get really swollen if they continue to do that. And the foreskin will no longer go back to its normal position. So that's why they end up having to do circumcision. And your concern with this happening, especially if parents have been trying to pull back with force. You get concerned about impaired circulation to that area, to the penis, okay? Because it literally gets that swollen, okay? Okay, epispadias and hypospadias. So epispadias is when your urinary meatus is on the upper side of the penis. Okay, so it's going to be on the dorsal side of the penis instead of at the tip of the penis. Okay, and hypospadias is it's going to be under the underside of the shaft. Okay. And a lot of times hypospadias also has chordae, which is when the curvature of the penis curves downward, okay? So it's not uncommon for that to happen. If it's really mild, like maybe the opening is kind of just towards the tip of the glans penis and the head, not right in the center, but it's kind of right at the edge, then they may not do surgery to correct that. But if it's like in this picture, either the hypospadias or the epispadias, they will do surgery to correct that. Okay. It's usually completed before 18 months of age. Otherwise, there can be a lot of complications if you wait too long. And then the other thing is if you notice a baby boy has epispadias or hypospadias, those kiddos do not get circumcised because they actually use that extra foreskin for the repair. Okay. So they leave those babies uncircumcised until they have the hypospadias or epispadias repair. They use that extra foreskin and then they do the circumcision during that process. Okay. If you guys have questions, just stop me. Okay. Exstrophy of the bladder. This is when the bladder is actually outside of the abdominal wall. Okay. And they usually notice this on fetal ultrasound. Like when baby's in mom's belly. Urine is going to continually leak from the bladder. The skin is going to become really excoriated and just broken down. They have a lot of wound care issues. Diapers are set under the infant instead of kind of all around the infant. So almost like a Chuck's pad of diapers to try to collect all that urine. Okay. Because it's going to leak out all over because of their bladder being in their anatomy being abnormal. They're going to, the biggest thing is that the bladder is covered by like a mucus wet mesh. So that way the moisture of the bladder and that integrity is maintained. So they're going to make sure, because sometimes it's really exposed. So you want to make sure that that's really saved by that little mesh layer. Okay. These kids are always going to be on their back essentially until they have that surgical closure, which is usually done within 48 hours of birth. So these kids aren't going to maintain like this for very long, obviously. But as you wait for them to go have surgery, that's kind of how you're going to manage it. You're going to put that diaper underneath their back and allow the urine to just kind of come out. So that way, hopefully it's not just sitting on the skin. Okay. But like I said, they're going to have surgery fairly quickly. Okay. So there's different obstructions that can cause problems then for the kidneys or other portions of the GU system. So the most common probably that all of us think of are renal calculi, so kidney stones, right? So that's going to cause blockage. The kidney stone is, as it tries to come from the kidney out to the ureter, it's going to stop and kind of block that off. And then that urine's not going to be able to get out around the kidney stone. And then what happens is you get a backup, right? Just like when you kink a hose or have a blockage, the water can't, flow normally. So it's going to back up. So that's when you get hydronephrosis. Okay. So that's the enlargement of the kidneys. And that's usually because of there's some sort of obstruction in the pathway that the urine flows. Okay. Polycystic kidneys, those are going to be a kidney that has a lot of little cysts all over it. And the kidney doesn't function as well because of those cysts. It gets a lot of the surface area, so the processing of the urine and the toxins and all of that, it's really not very effective. So a lot of times patients who have polycystic kidney disease, they end up having to have a kidney transplant at some point because their kidney function becomes so poor. So if kids have tumors or they have narrowing, so strictures, or they have kidney stone that they're unable to pass, then they're going to need to go in and correct that obstruction. Hopefully, so in that sense that the hydronephrosis doesn't happen, okay? So if there is, sometimes during surgery, they have to do a diversion. So that means like they create a stoma, like you do with a like a colostomy bag, right? So you create a new opening externally. That's what this is showing. This is a urostomy. So instead of going to the bladder, both the ureters are coming here, and then they've created a stoma or an opening externally based off from the ureters. So that is a urinary diversion. And at times this needs to happen as they manage the bladder and do surgery with that, or have to manage some other things related to various defects. Toddlers, a lot of times because they have urostomies, it's really hard to get those kids potty trained. They're not going to be able to manage their U-bag and all of that. So parents are still going to have to do a lot of helping with that for toddlers. Even school age kids, same thing. I mean, they can do a little bit, they can manage it a little bit better than toddlers can with, switching out their bags and things. But a lot of times school age kids, they may get made fun of. They may have kind of some body image troubles because of their urostomy and their U bag. So just being aware of that. And then adolescence, of course, adolescence is all about body image developmentally, right? So if they have a urostomy or, a colostomy, that's really going to affect their body image and their overall self-esteem. Okay. Okay, here's a critical thinking question. So the parents of a 4-year-old boy explained to the clinic nurse that for weeks the child has been irritable, listless, and even has developed a poor appetite and gained weight. What signs and symptoms should the nurse look for? And what conditions would the nurse suspect? And then once you figure out the condition, what would be appropriate nursing interventions? Anyone?
I would say maybe bladder distension.
Yeah. So what would you teach those parents, or what intervention could you do?
Probably frequent urination, having them prompt them to go to the bathroom a little bit more frequently.
Yeah. Yeah.
Check their INOs.
Yep. What about if they're really, really, really distended? Like you do a bladder scan and there's like 600 in their bladder and they just tried to go pee. Would you do something like a catheterization?
Catheter.
Yep. Yep. Even just a one-time straight cath um, sometimes has to happen. Okay. Okay. All right. Here's some more objectives. Okay. A UTI. So in elderly patients, your most common sign of a UTI is like confusion and altered mental status, right? So not that that can't happen in kids, but it's not usually the first sign. Usually the first sign is kids have been totally potty trained and all of a sudden they start having accidents. Okay? That's going to be one of your first signs for younger kids. For older kids, of course, they're going to have more of the urinary frequency, the burning with urination, things like that, more common kind of things. But for littler kids, those early school age kids, accidents is going to be one of your first signs a lot of times. UTIs, you guys probably all already know this. They're more common in girls than in boys. That's just because of our anatomy, our urethral opening and the location of it. It kind of unfortunately sets up the perfect storm for a UTI. With teaching parents, sometimes, especially dads, they don't have female parts, so they don't know how to appropriately change diapers sometimes. So walking parents through, like making sure you're wiping front to back, talking with toddlers who are, working on potty training themselves and wiping themselves, teaching them to wipe front to back, and parents working with them on teaching that. That can be really helpful. The other thing too is if kids often have, especially girls, if they often have UTIs or they've had a lot of troubles with dysuria or something like that, making sure that they're not doing bubble baths often and sitting in that's a really common irritant to that area. So making sure that they're not doing that if they're having troubles with UTI. Okay. Most commonly, it's caused by E. coli. Obviously, think like anatomically, E. coli is often in stool. Okay. So a lot of times what happens with little girls is they get their diaper changed and maybe a little stool comes in there into the urethral area and causes an infection. Okay. Normal urine is acidic, and then alkaline urine, so more basic urine, that's when you see more UTIs. Okay. I don't know why this PowerPoint's going so slow today. Okay, so how are you going to treat UTI? First off, how are you going to find out that kid has a UTI?
Or irritable.
Analysis.
Yeah. What test are you going to do to find that out?
I'm gonna get a urinalysis.
Yep, a UA. Good. And then sometimes you have to do a urine culture too to see what that bacteria grows and make sure that the antibiotic that the provider prescribed covers that bacteria. So usually if they're little infants, like a year or less, they're going to be hospitalized for IV antibiotics. But if they're over a year and they'll take their meds, then they can do oral meds at home. Okay. Obviously, with your parental teaching in a kiddo with UTI, making sure that they take their entire antibiotic as prescribed is always important. And then making sure that, they're doing those hygiene promotion things. So making sure the little girl wipes from front to back, not doing a lot of bubble baths, not wearing really tight cotton underwear, nylon underwear. And that they're actually going to the bathroom. Okay. Because sometimes kids, when it hurts to urinate when they've had a UTI, then they'll start refusing to go to the bathroom and they'll hold it as long as they possibly can because they're scared that when they go pee, it's going to hurt. So just making sure that that's not the case, that parents really encourage kiddos to urinate appropriately. Okay. So we kind of already talked about this kind of some prevention things. Also, hydration. I can't tell you how many little kids tell me that they hardly drink any fluids all day, especially when they're at school and preschool. But hydration can be helpful too in kids that frequently have UTIs. Okay. Okay, nephrotic syndrome. So this is what kids with nephrotic syndrome look like. I know this picture is kind of a little bit difficult to see, but they're super swollen. They're going to have low albumin. They're going to have a lot of edema. And then they're going to have they're going to be so swollen everywhere. They can barely open their eyes. That's how swollen kids with nephrotic syndrome or nephrosis get. So this is going to be high protein in the urine. They're going to have the edema and they're going to have low albumin in their blood. Okay. It's more common in boys. It's related to a T cell dysfunction. Most commonly in kids preschool age to early school age, so like 2 to 7 years of age. Your most common signs you're going to see is generalized all over the place edema. They're going to have weight gain. They're going to be listless. They're going to be irritable. They're going to have poor appetite. So looking back to our question earlier, it was probably nephrotic syndrome, right? No. So these kids are also going to have distension of their bladder, but and when you do check their urine, they're going to have a lot of albumin in their urine and like very few red blood cells. And when you check their blood, they're going to have really low albumin and they're going to have not as many red blood cells. And a lot of times they're going to be neutropenic, which means that they have absolute granulocyte count of less than 1,000. So they're going to be really prone to getting infections. So your treatment for nephrotic syndrome or nephrosis is going to be to reduce the protein in their urine and improve the edema. A lot of times, kids who are on steroids, this can kind of cover up infectious signs. So making sure that if they're on steroids, you're really monitoring closely for infections. Okay. Adding salt is what one of the key things that you're going to tell parents if they're having edema, you're going to be adding salt to foods. Okay. Extra strict I&O, you're going to be positioning them to try to help lessen that edema. They're not going to be getting their vaccines when they're on their immune suppressants, such as steroids, okay? Because they won't have a good immune response to that vaccine and they'll have to get it again anyways, okay? They don't only do diuretics. Those aren't overly helpful. Okay.
Question.
Uh-huh.
Is there live vaccines or just
Across the board, but especially with live vaccines, but across the board, if you have a kiddo that's on an immune suppressant like a steroid, or they're on chemotherapy or something like that, then you want to be really careful with them getting vaccines.
Okay.
But yes, live vaccines are even more problematic in those kids. Okay. All right. Glomerular nephritis. So this is something that happens with group beta strep. So group A beta strep. Okay. This is strep throat is group A strep. There's a lot of different types of strep. So after the kiddo has strep throat, you know, their throat's feeling better. So then they start refusing to take their meds. Then parents are like, okay, I'm not going to fight you on meds because your throat's feeling better. Well, then they have an antibody antigen reaction, which is a somewhat a form of an allergic reaction. Not like anaphylaxis, okay, but it's kind of another immune reaction, okay? And what happens is those antibodies then start fighting the glomerular tissue in the kidneys, okay? They start thinking that that's the infection. And then what you see is both of the kidneys are affected, excuse me. And these kids are going to have really significant swelling all over, but mostly in their extremities. And they're going to have really high blood pressures. And that's all from an antibody antigen reaction with the group A strep and not completing their antibiotics. Okay. Okay. Here's a critical thinking question. An 11-year-old has been diagnosed, has been diagnosed with a UTI. What are key points that the nurse should teach the patient and her parents?
She needs to wipe front to back.
Yep.
No bubble baths.
Yep.
Wear loose clothes.
Yep. Good.
Increase water intake.
Yep.
Make sure she's voiding all the way.
Uh-huh. And how about taking her antibiotic or whatever she's on for the UTI too? Okay. Good. All right. Now we're going to talk about Wilms tumor, which is a form of kidney tumor. So Wilms tumor, so this is also called nephroblastoma. You can see that written here. It's the most common cause of kidney cancer in kids. Usually kids have just a tumor in one of their kidneys, but about 5% of kids with Wilms tumor actually end up with tumors in both kidneys. So most commonly it occurs before age 3. They a lot of times have no symptoms during early growth, like they grow appropriately. They don't really have any delays. And then usually what happens is parents all of a sudden find, like, you know, they might be tickling their belly or something, or they're changing them and they push on their belly and they feel a tumor. Okay. They diagnosed this with a IV pilogram that looks at the growth of the tumor. It looks at the type of tissue that the tumor is. And then also most commonly that tumor is usually encapsulated. So it's, you know, totally closed kind of around the kidney. Kids might have high blood pressure, but really honestly, when I took care of kids on the floor with Wilms tumor, I mean, if their tumor was really, really large, they would have high blood pressure, but it was oftentimes kind of a late finding. Okay. Wilms tumors are really, really fragile. So what happens if you continue to push on that abdomen often is actually portions of the tumor will kind of flake off. And then that can kind of promote metastasis. So, or like, movement of the cancer to other regions. So you want to make sure that once you know that that kiddo has Wilms tumor, you are not palpating their abdomen anymore. Okay. Okay. So a lot of times these kids will have like a little sign by their hospital bed that says like no abdominal palpitation. Okay. They do go in and remove the tumors. That's one of the first. So here's a little kiddo with Wilms tumor. So a lot of times their bellies, they just look super tight. And then the tumor's obviously on this side because look at that protrusion here and that distension on that side. So they're going to be having surgery to remove as much of that tumor as possible, and radiation and chemotherapy. This is a combo approach to managing Wilms tumor. Okay. A lot of times that kidney and the tumor are removed, and then they do biopsies and things to confirm diagnosis and to help stage that tumor. Your nursing care, obviously preoperatively, making sure that their vitals and things are stable. They're not having fevers, things like that. And then post-operatively, you're going to do routine post-op care like you would do on any patient. So frequent vitals, frequent assessments, things like that. And then still no abdominal exams. Like I said, even after surgery, it's really honestly kids with Wilms tumor. Once we knew that they had Wilms tumor, I don't think I ever touched one of their bellies again after that as a nurse. Okay. Okay, hydrocele. So this is an excessive amount of fluid around, so in the scrotal sac, but around the testicle. Okay. So then you're going to see that scrotal sac swell. Okay. If kids have continued hydrocele after a year of age, then that is corrected by surgery. This is a fairly common finding on exam. And it's usually, I mean, you can usually notice usually one side of the scrotal sac and testicle appears to be a lot larger than the other side. And then when you feel that area, it feels very fluid, like doesn't feel hard or like venous feeling. Okay. Goodness, my PowerPoint is going so slow. Okay, cryptorchidism. So this is also known as an undescended testicle. So this testicle stays up in the abdomen and does not come down into the scrotum. Okay. A lot of times it's more common that they only have one undescended testicle, but there are times that some boys have both testicles that are undescended. Okay. A lot of times these kids run the risk of having fertility problems down the road, especially if it's not addressed early on and they don't have surgery to take that undescended testicle and put it into the scrotum like it should be. Okay. And also a lot of times kids with cryptorchidism also have inguinal hernias. So they're also going to have a herniation through that inguinal canal of the testicle. Okay.
So, can they come down by itself eventually without?
So Sometimes they initially have kind of an undescended testicle. And sometimes it can work its way down, but a lot of times they don't even give it the chance because they worry about fertility.
I was only asked because they had, when my son was a couple months old, they
Uh-huh.
had said that basically one of his didn't descend either.
Uh-huh.
They did an x-ray and it showed that it didn't descend. And I think they made me wait about 2 weeks and then took him for another one at Children's, and it had just descended on its own.
Uh-huh. So what will happen a lot is kids will have what we call retractile testes. So the testicles might kind of go up slightly into the abdomen, but that pathway is still open. So that testicle can kind of just freely go up into the abdomen and then down. By a year of age, they should be staying down in the scrotal sac at all times. So if they're not doing that at that point, then you'll see kids get surgery. But if it's an undescended testicle and it doesn't appear that there's like a pathway for it to descend, then that's when they'll do surgery right away. So in your kiddo's case, he must have had that pathway and it just was kind of retracted up, and then decided to come down like it needed to. Okay. Okay, so crypt orchidism. So this is going to tell you treatment wise what they do. So sometimes they can't get the testy into the scrotal sac in the right position. So they actually have to take that testicle, and that's called an orchiopexy. So they remove that testicle, and then of course that reduces their chances of fertility down the road. They also will give kids HCG or human chorionic gonadotropin to try to get it hormonally, that testicle to descend. Sometimes that will make a difference. But usually kids have to have surgical management of this. Okay. If kids have an undescended testicle or cryptorchidism, they are at increased risk for testicular cancer later in life. Okay. And this is showing you an inguinal hernia in this picture. So here's your inguinal canal, and then it's perforating through or
Okay.
through.
You
Okay.
said the orchoplexy is a what? It's a test.
It's the removal. It's a surgical procedure. That's the removal of the testicle.
Okay.
Mm-hmm. So sometimes they have to do that if it won't remain in place in the scrotum. Okay. So this is showing you an inguinal hernia where then the testicle has actually herniated into the inguinal canal as well. Okay. That needs surgery. So your nursing care for cryptorchidism is going to be, obviously, you're going to, that kiddo's going to need scrotal support for a period of time. So a lot of times they'll have some sort of like scrotal support underwear object that they put in, and then they put their underwear on or their diaper on then as well. The other biggest, I would say, piece is teaching these boys that then they need to make sure that they're doing testicular self-exams when they're older because of their increased risk for testicular cancer. Okay. And then also these boys a lot of times will say, like, is there going to be something wrong with like my penis or anything like that later in life? And usually there's no issues with the penis. It's just affects the testicles. Okay. Okay. So if they have to have urinary or genital surgery, especially between the ages of 3 to 6 years. A lot of times their puberty is going to be delayed. Okay. And you have to think kids who are 3 to 6 years of age, they're starting to notice the differences between boys and girls. And they're getting more curious about those differences and about themselves. So, you know, masturbation might be a normal kind of occurrence that happens in this age group. But obviously, if they've had some sort of surgical procedure, you're going to want them to hopefully not be doing that because of the risk of infection. Okay. So you might have to work with parents on that. And then working through the negative impacts potentially that those kids having GU surgeries can happen on growth and development because of this age group being curious about those sexual characteristics. If they're having surgery while they're in this age range, then that can kind of affect the normal growth and development. Okay. Goodness. Okay. So during your routine monitoring, a 6-year-old who underwent renal surgery 24 hours earlier, and you notice that the kid has a fever of 102. So what would you suspect and what interventions would be appropriate? What's going on with this
I
kiddo?
would say infection.
Mm-hmm.
Obstruction.
Yeah. Yep, an infection for sure, because the fever, right? So what would be an appropriate thing for you to do as a nurse if you're thinking this kiddo just had surgery and now they have a fever?
Urinalysis.
Yeah.
Yes, call the doctor.
Yeah. Let the provider know, right?
Mhm.
They want to see if the bladder's distended.
Yep. And check the surgical site, right? Like externally. Yep. Good. Yeah, and then if that kiddo has an infection, you know, they might end up on IV antibiotics or what have you, depending on whatever the provider decides to order. But goodness. Okay, so now we're going to move on to chapter 30. So this is going to be skin conditions. Here are your objectives. You guys are more than capable of reading those, so I'll let you do that on your own time. Okay, so the main function of our skin system is protection, right? From infections and other potential causes. So skin is the first line of defense, okay, from diseases and infections and trauma and all of that. It prevents electrolyte loss and water loss. It can regenerate and repair itself. I mean, think about you get a cut, it ends up being a scab, and then your normal skin returns. Okay. It also prevents the passage of harmful chemical agents into the body, the muscles and organs. Okay. So skin permeability or perspire. So kids less than 3, a lot of times they don't sweat. Some kids can, but usually they don't get the ability fully to start sweating until 3 years of age, which I always think is interesting. And then kids who are preterm, so NICU babies and things, that's going to come later, even than 3 years for them. So some of them might even be closer to 4 before they're sweating. Okay, so there's various skin conditions. usually it's a sign of a systemic disease process that's happening. And some of them are congenital, so some kids are born with. Skin color is obviously an important thing to monitor when you're doing your assessments as well, okay? Sometimes you can do skin tests if it's an allergic thing to diagnose allergies. So how they do that is on kiddos' back, they do like a little prick test. So what happens is they do the little prick test and then that allergen is injected into that little opening in the skin, and then they monitor that for if that kiddo has a hive-like reaction to that allergen. And that's how they end up diagnosing a lot of or a lot of allergies, environmental and like seasonal allergies. Okay. Hair color. Hair is obviously a part of the skin system, the integumentary system as well. Okay. Based on that kiddo's nutritional status, their hair may be brittle. They may have really nice non-brittle hair. It may grow. Their hair may be falling out. And so that's always a picture of a nutritional or a disease process going on. And then sometimes kids' hair can change, and their skin kind of coloration and appearance can change with certain medications that they're on or certain interventions that they've had to have based on their diagnoses. So obviously with chemotherapy, what happens to our hair? It falls out. Well, then sometimes when hair grows back, it can grow back a different kind of it may be curlier, it may be a slightly different, darker color after chemotherapy. Okay. So obviously what you should look at when you're looking at skin conditions is the size, the color, the configuration. So is it all in one small spot, or is it generalized all over? If it's itchy or if it's painful. And then looking at the area around the skin lesions. Okay. So one of the most common complaints with skin conditions is itching. Okay. So kids are itching. They already have kind of irritated skin. They keep scratching, they scratch an opening, and then a lot of times what happens is they get a secondary infection of strep or staph or yeast sometimes, just because all of those things occur naturally on the microbiome of our skin, okay? So when applying skin creams and ointments, it's really important to make sure you tell parents or kids to wash their hands before and after. So that way, hopefully that reduces a little bit of the risk of infection, and obviously try to have kids not be itching at it, but sometimes that's nearly impossible. So you can give those kids something like Benadryl or like calamine lotion or something like that to try to help some of the itching. Or a steroid cream also, that helps the itching. Ointments are usually better absorbed than creams too, especially if kiddos have eczema. Those ointments are really hydrating. Okay. Okay, so a macular rash or a macule, that's flat. Okay, so something like freckles, those can be a macular rash. Okay, so it's just a flat skin lesion. Okay, a vesicle, that's an elevated fluid-filled blister. So something like chickenpox lesion or like a cold sore. Okay, or a herpes lesion. So that will be elevated and it will look like it has fluid in it, okay? So that's a vesicle. A crust is just a scab. Okay. A papule is an elevated area. So it's just elevated. It does not have that fluid-filled blister kind of a appearance. So something like a pimple. Now, if your pimple has pus underneath it, then that's considered a pustule. Okay. But if your pimple's raised and it doesn't have pus in it yet, then that would be a papule. Or you'll hear people say papular rash. Okay. A pustule, like I said, it's elevated and it's filled with pus. So most commonly acne, right? But also impetigo, which goes along with staph and strep infections. A wheal is most common with allergic reactions, so like a hive. So it's going to be red raised, and it's going to kind of have an irregular shape to it. So it's not going to be real circular. It might kind of have jagged edges around the circle. Ecchymosis is going to be bruising. Okay. Any questions about those at all? Okay. Okay. Oh, sty. So a sty or hordeolum is inflammation of the sebaceous gland around the eyelid. Okay. So these are really common things that you see in kids. And there's not a whole lot that you can do about them. You a lot of times like warm compresses, and then eventually they'll go away on their own. They can be painful, but you're not going to get like they don't need antibiotics or anything like that. It will go away on its own. And like I said, warm compresses and then pain management if they're having pain with it. But that's just inflammation of the sebaceous cyst, or excuse me, sebaceous gland. Okay, a strawberry nevus, this is also called a hemangioma. Okay, so some kids there, you can see the difference. So hemangiomas can start and they almost kind of look like bruises, like a more red bruise, and then it starts to become more prominent and more elevated and raised. You can see some of these disappear without treatment, but a lot of times if they're raised like this and really red, then they actually do end up getting treatment with topical Timitol is most common. And that helps with decreasing the raised and becoming more flat and less red. Sometimes kids with hemangiomas can have some bleeding or clotting dysregulation. So a good thing to send them to hematology. Or a lot of times they'll have a hematologist that has looked at their blood work. Okay. Essentially what this is it's a bunch of dilated capillaries in the dermal space. So it's kind of just an accumulation of those capillaries in the dermal space. And like I said, sometimes you see babies and they're newborns and you don't see a hemangioma on them at all. And then, or you might see something like this picture, like a little bruising kind of, or looking like a little strawberry mark or something. And then they come back and it's much larger. Okay. Port wine nevus or port wine stain, you've heard that called. So this is going to be present at birth. This is dilated capillaries in the dermal layer as well. But these lesions are going to be flat. Okay. They're going to have purple to pink appearance. And usually it gets darker as the child gets older and it will not go away. Okay. So they do actually now have lasers that they'll treat these with. with like a skin laser, and that does help the appearance. Usually it still has some of the redness or the purple appearance, but it gets a lot better. Okay, so cafe au lait spots or cafe au lait macules. So that is what you see here. So it can be if they have more than one cafe au lait spot, especially if they have more than like 4 or 5, then you get concerned about neurofibromatosis, which is a chromosomal abnormality, or tuberous sclerosis. So if you notice kids with cafe au lait macules, then you likely that provider would be referring those kids on to neurology or genetics for further workup to make sure that they don't have neurofibromatosis or tuberous sclerosis. Okay. Okay, hypopigmented macules, those are going to be, you can see that in this picture. So areas of hypopigmentation, so kind of leaf shape or like whitish oval appearance, that can also be associated with tuberous sclerosis. Okay. Okay, so butterfly rash. So that is going to be a rash that occurs over the nose and the cheeks. Just like this, it kind of looks like a butterfly. A lot of times it kind of comes up in and around the eyes. This is very common with kids who have systemic lupus. Okay. And it gets worse if they're out in the sun. This rash is going to become more prominent. A lot of times too, as it becomes more red and irritated, then you start to see that scaling of the skin and kind of opening up of the skin. It can also be in the perianal area as well. And the scaling skin, that is a lot of times happens with kids who have zinc deficiency. Okay, so you'll see the scaling skin. They won't be gaining weight all of a sudden as well, and maybe they're having like frequent diarrhea. That would be a good sign of scaling skin. Okay. A vascular birthmark. So this can happen. These are hemangiomas, okay, as well. Usually you get concerned if they're on the face or chin or neck area, because you get concerned that as that hemangioma grows, like you could see how drastically the strawberry nevus grew, right? That's a form of a hemangioma. As those grow, you get concerned about them impeding airway. Okay. So kids with vascular birthmarks or hemangiomas that are in areas like that, a lot of times those then get removed. Okay. And sometimes kids can have internal hemangiomas that you can't really see externally. So sometimes they'll present with, you know, like shortness of breath or something, and you don't see like this picture, this classic hemangioma look. It's more internal collection. Also, if their hemangioma is like along their spine on their back, then you get concerned about there being spinal effects. Okay. Okay, a female adolescent has a port line nevus. since early childhood. She now has severe acne. She doesn't understand why she is susceptible to these skin disorders. She asks whether she's done something wrong. So how should the nurse respond, and what advice should the nurse give her? So do you think that, like, why do you think she's maybe more prone to acne?
Because she has the port wine.
Uh-huh. Yeah, her skin's already irritated, right? Mm-hmm. Yeah.
And I would let her know it's not her fault. It's just stemming from something that she already has. It's just normal.
Uh-huh.
Something we just need to watch and kind of control.
Uh-huh. And you would manage her acne, you know, like making sure she's washing her face and things like that, just the same as you would any other kiddo. Okay, good. But yeah, reassure her that it wasn't her fault or wasn't something she did wrong. Okay, now we're going to start talking about acne and some things to do with that and eczema. Okay, so miliaria. So this is your prickly heat rash. When you see kids with heat rash, that's what miliaria is. A lot of times babies who have maybe been in long sleeve onesies, driven in a car, and then you get them out, a lot of times they'll have that prickly heat rash. So it's going to be a raised rash. A lot of times it's in areas of body heat or excessive moisture. So like armpits, back, skin folds, okay, kind of in those areas. That sweat is retained in the sweat glands, and then the glands become blocked, and then they get irritated, and that's where you get that heat rash. And then they're gonna be tiny little pin sized, red raised, which is papules, okay? Might be itchy, might not. A lot of times, like I said, skin folds, diaper area. So making sure that those kiddos don't have too many layers on. And then maybe taking them out when you get home, bathing them in, you know, some tepid water. Okay. And then making sure that they're getting frequent diaper changes. Usually I tell people to not put a whole lot on these prickly heat rashes. They'll go away once you cool the kiddo down. Okay. All right, Enrico, this is chafing. Okay. So it's a dermatitis that happens in skin folds. A lot of times diaper areas are a lot of times the most common area that Enrico happens. The patches are going to be really red. They're going to look moist. Obese kids a lot of times are more prone to this because they have more skin folds, okay, and more area that moisture can kind of hang on to. Obviously, urine, feces, heat, moisture, that's all going to make it worse and more red. Drooling, you know, in the neck folds, drooling, foods, you know, babies, they're bottling and they are leaking out the side of their mouth, or they're breastfeeding and leaking out the side of their mouth into their little chunky neck folds. That's probably one of the most common places to also have Enrico. And how to prevent this is to try to keep those areas clean and dry. Okay. And sometimes, you know, this, like I said, sets up the perfect storm for a secondary infection because it's red and irritated and open, essentially. Okay, because it's so excoriated. So sometimes they may get a yeast infection or a staph infection. Okay. All right, seborrheic dermatitis. So this is cradle cap. Okay, and so that's the inflammation of the sebaceous glands. You're going to get that thick, yellow, oily crust scales. Okay, most commonly on the scalp and the forehead, hairline, but it can be like on ears. like back behind ears as well. Okay. Frequently in newborns and infants. It can also happen at puberty. And treatment, you're going to be shampooing the hair on the consistent basis. And also you can have parents do baby oil or mineral oil. That loosens those scales. You do not want to do olive oil. Some people have done olive oil, and what can happen is it actually worsens that sebaceous gland irritation and causes more of the crusts to develop. So some people get confused and think that their kiddos have eczema when they have seborrheic dermatitis, but eczema a lot of times is itchy, and seborrheic dermatitis, usually kids with this aren't even bothered by it. Okay. Diaper dermatitis. So this is a terrible diaper rash, goodness. So obviously they are in prolonged contact with urine, feces. You know, if it's happening in their underwear or something like that, then it can be from laundry soaps or like friction of the underwear being too tight and kind of rubbing. It can also happen if babies are allergic to the foods that they're eating. Or if they're in contact with like chemical irritants. So if they're irritated by their diaper, you know, if there's a scent to their diaper, a scent to their diaper wipes, then you can see diaper dermatitis happen. And if it's really beefy red, like these two pictures, a lot of times that's going to be a candida infection, so a yeast infection as well. So frequent diaper changes, and these kids are going to need a barrier skin cream with every single diaper change. So, you know, diaper cream, a zinc-based diaper cream, but also if they have a candida infection, they're going to need antifungal cream as well. Okay. And I actually do, as a provider, when babies come in with rashes like this, that's so bad, I have parents do mupirocin or Bactroban, which is an antibiotic ointment, a zinc barrier, so like Desitin, the nystatin cream, which is for yeast, and then actually Maalox or Mylanta, which are antacid kind of medicines, which sounds crazy, and you mix all of those together and then you put that on the baby with every diaper change, and it really takes care of the diaper rash. And what the Maalox or Mylanta does, it kind of is like a numbing agent. But then that way you're covered for staph or strep and yeast, because obviously this is really open and angry. So anything that's on the skin that's a bacteria that could cause a secondary infection, it totally will. Okay, acne vulgaris. So this is inflammation of the sebaceous glands and hair follicles. So our sebaceous follicles enlarge through puberty. That's why you see increased amount of that sebum, which is a fatty substance, and then it plugs that follicle, and then that's when you see that inflammation happen. So a comedo is a plug of either keratin, sebum, or a bacteria. So an open comedo is a blackhead, okay? And then a closed comedo is a whitehead. So like those pustules that you'll see, okay? Closed comedo acne is probably the most common. Okay, so acne vulgaris, what you're going to do is teach those kids routine skin cleansing, making sure that they're not doing a lot of greasy hair products or greasy cosmetics. or putting on a lot of makeup when they're having an acne flare up. And then if they're washing their face too regularly, that can actually get rid of the good skin protectants on your skin. So making sure you're telling kids to not be doing that, because that can actually worsen the acne and worsen the irritation. You're also these kids are probably going to be on topical or oral medications. So like oral antibiotics sometimes are used for kids who have really bad acne, or topical antibiotics. So something like clindamycin, topically to those affected areas. And then also salicylic acid or benzoyl peroxide are really common facial cleansers for kids with acne. Okay. And then the biggest thing with teenagers across the board with treatments, they're not always the most likely to follow through with their treatment. So making sure you're teaching those teenagers that if they want their acne to get better, they need to be doing those treatments. Okay. All right. Herpes simplex type 1. So this is most common on the face. So this is the most common cause of cold sores, or you'll hear fever blisters. So this is a lot of times it's communicable. So a lot of times kids get these from their parents or from other people who, they've come into contact with who had a cold sore, who had HSV flare up. Type 1. So as kids are getting cold sores, they might kind of feel tingling or itching or burning on their lip. And then usually those vesicles and then the crust over the top forms, and it usually takes about 10 days to heal. They're most infectious during the early phase of the outbreak. So when those vesicles are there and they're starting to sense that tingling and that itching is usually when they're most infectious. It's really common for there to be reoccurrence. It usually is activated or starts from stress or sun exposure, or for females, menstruation, fever, any kind of stressor on the body can cause the cold sores to present. Okay. And most commonly treated with antiviral medications. There are oral antivirals that you can take, and also topical. The other thing, nursing wise, if you are a mom baby nurse or a pediatric nurse or NICU nurse, and you're caring for a little baby and you yourself have a cold sore, you want to make sure you're disclosing that and not caring for that baby, because there's a potential that that virus could shed and they could acquire then HSV1. Okay. And in little babies, that's really problematic, because that's when you see the herpes encephalitis, that inflammation in the brain from herpes virus. That's why if you've seen people say like, don't kiss the babies, that's the most common reason why, is because herpes can go straight to the brain for little babies. Okay. Infantile eczema, or also known as atopic dermatitis. So this is an inflammation of hypersensitive skin. So you're going to see the breakdown of dermal cells and the formation of the intradermal vesicles. It's rarely seen in breastfed infants until they start eating additional foods, just because additional foods can kind of trigger that hypersensitive skin and cause eczema to flare up. It can be a sign of sensitivities with like whole milk or dairy products. Can a lot of times make it worse. It's also going to be just naturally worse in the winter time because of the dry cooler environment. And these flare-ups can become really easily infected. Okay, just like any kind of skin condition is more easily infected than a kiddo that has normal, healthy skin. Eczema kids can get herpes infection within their eczema flares up. So make sure that if you have a kiddo with eczema and their eczema is really flared up, and then you would have a cold sore in that scenario too, you probably wouldn't want to be the provider of care for that kiddo, because potentially then they can get really high fevers and then they get the herpes vesicles within their eczema flare. So then they're kind of dealing with two different causes of their flare up. You may see some flare of eczema after they get immunizations, and then you'll see these kids have increased IgE and eosinophils. So those are just your allergic indicators. So a lot of times kids with eczema are going to be more your asthma kids, your allergy kids. Okay. Treatment for eczema, it's going to be aimed at relieving the itching and hydrating the skin and improving that inflammation, and then obviously preventing the secondary infections. So you're going to do emollient baths, which can be a mixture of baking soda or cornstarch and oatmeal all mixed together. Have that kiddo soak in that bath, and then that bath oil helps to lock in that skin moisture. The other thing too, I always tell parents with kids with eczema is after they get out of the shower or the bath, don't let them totally dry off. Have them kind of drip dry a little bit, and then put their eczema creams on or their lotions, because that's going to lock in the moisture. And a lot of times when kids are having a bad eczema flare, that's what they need. Also, bleach baths, which that sounds terrible for a kid with eczema, but it's a tiny amount of bleach in the big bathtub. And what it does is it kind of helps dry out that eczema flare, and it also helps then prevent the risk of secondary infection in that area. So they would do that, a couple of times a week if their eczema is really flared up. These kids are going to be on corticosteroids, so they're going to have topical steroids, topical antibiotics a lot of times, and then, Benadryl or something like that for itching. Sometimes they require oral steroids and oral antibiotics if their eczema is, really profound and all over their body. Then that would be when they would get the oral versus the topical. Okay, so making sure you wash the ointments off completely before you apply the next layer of their ointment. And then cortisone creams, so your corticosteroids, sometimes those can cause thinning of the skin if they're using them too frequently. So you want to make sure that you teach them that, every couple of weeks you need to give the cortisone or the corticosteroid topical a break for a week or two. And then, like I said, apply those topical medications after warm baths. Don't let them totally dry off. And then make sure that parents are putting the ointments on in the same area that the hair in that area is growing. That just helps with absorption. And then making sure that they're not, globbing on a huge amount of that ointment in that one area, that they're using an appropriate amount. Sometimes if kids eczema is really, really bad and they're really bad with itching and they're like an infant or a young toddler who can't understand that they can't be itching, sometimes they need to use elbow restraints to help keep those kids from itching. Okay. And then if you suspect that there's a viral infection, so if a kiddo has even a viral upper respiratory infection and their eczema is flared up, you want to make sure to tell those parents to not be doing their steroids. topically during that time. Okay. Staph infection. So like I said, there's staph naturally on our skin and in the environment. So what happens is at any point there's an opening in the skin, that staph is right there. So that's almost that's the most common cause of sepsis and in any age group, just because it's so naturally occurring and opportunistic on our skin. If the infant has MRSA, then that child has to be in contact isolation anytime they're hospitalized. Okay. And at any point, if they test positive for MRSA, then anytime they come in the hospital, then they have to be isolated. If you notice like small pustules on a newborn, you have to report that to a provider immediately. That's pretty suspicious for staph. Antibiotic ointments are used in situations where there's not a really large area, or when the kiddo's not having systemic signs like fever, decreased appetite, lethargy, things like that. If they're having those secondary symptoms or those more progressive symptoms like fever, lethargy, decreased appetite, then they get IV treatment. Scalded skin. So this is caused by Staph aureus. So what happens is those lesions become, they start kind of like slightly red, which you can see here. Okay. And then they become vesicles and start peeling. So this is caused from a staph infection on the skin. And then it becomes really, really red, and you still have that peeling going on. A lot of times you get concerned about like burns or things like that with kids with scalded skin. Like, is this child abuse? Were these burns and not the staph infection that are causing this? And then actually, surprisingly, even with all of this terrible peeling and redness and irritation, the skin a lot of times resolves and improves without any issues. It's like they don't have a lot of scarring after the fact. Impetigo, this is caused by both staph and strep, and it's group A strep most commonly, so the same sore throat strep that we have, and the same strep that causes glomerular nephritis. Okay. So what you're going to see is you're going to see bullous formation, which is it's essentially the same as a vesicle. Okay. So it's going to be that fluid filled blister that's going to start. And what's going to happen is that bullous is going to open up, and then staph is going to get into that area. Non-bullous, so that can happen as well. It's usually seen more in kids and adults, whereas the bullous is seen in more infants. And then that means that there's just not that vesicular part of it. So it's just almost like a lesion, like a macule, or a little papule. It doesn't have the fluid in it. Okay. It's very contagious, impetigo is. So the best thing is as soon as you think this kiddo has impetigo, they're going to, also, I don't know why it doesn't say in this slide, this is kind of an older thing that they give oral and IV antibiotics. If it's not really significant, so like for this kid that just has a few little spots, they would get topical antibiotics. So kids can get topical antibiotics if it's not really significant, like Bactroban, because that covers both staph and strep, or oral antibiotics. And of course, if their entire body or most of their body is looking like this and they're having fever and more systemic kind of signs, then they'll get IV antibiotics. But a lot of times parents will come in before it looks like this even. Okay. Fungal infections. So this is going to be like your tinea capitis. So your, or your, like ringworm, things like that, fungal infections. So a lot of times what you'll see is you'll see some redness, and you'll see hair loss in that area. So fungi are larger than bacteria. It's most common in the hair, nails, and the stratum. Okay. Tinea curris, so that's going to be in the genital region. That's called jock itch. It's going to be really, so all of these will be incredibly itchy. Okay. If it's fungal, it's really, really itchy. Okay. Tinea pedis, that's going to be the between the toes lesions. So that's going to be your athlete's foot. Okay. It's going to be scaly. It's going to be red. And a lot of times, if it's on the body, you're going to see some central clearing. That's the ringworm piece of it. So it's going to have redness all on the outside, and then in the center, it's going to be just kind of skin color. Okay. So for treatment of fungal infections, antifungals. So a lot of times it's topical, but there are oral antifungals that some kids have to take if it's significant. Okay. Head lice, this always makes my head itch when we talk about head lice, no matter what. This obviously, there's different forms of head lice. Pediculosis is the name for head lice, and then it's based on if it's head lice, pubic lice, body lice. Okay. So pediculosis capis, or capitis is the head lice. Pediculosis corpus is body lice. Okay. So corpus on your body, just like tinea corpus is on the body. Okay. And tinea capitis is on the head. Okay. And tinea pedis is on your feet. Tinea curris is the, in your groin region. And pediculosis pubis is going to be in your pubic region. Okay, so that's going to be what is referred to as crabs, or pubic lice. Survival of lice depends on the amount of blood that they're extracting from that person. So lice has to have a blood source. So if lice, like somebody brings home lice and it, occurs then in your carpet. Now I see you guys are all itching your heads because we're talking about lice. Anyways, so it can come home on kids, and then what happens is if that lice hops off and it becomes embedded in your carpet, it can survive for minimal time off of the host. It really needs that host, that blood, to continue to thrive. Okay. Treatment wise, topical treatment, so shampoos is probably the most common. There are oral medications that you can take, but parents still have to do the work of bagging up all of the stuffed animals and such, and allowing them to remain there for 2 weeks. So that way, all of those lice potentially on those stuffed animals are dead. And then treatment, usually you treat once and then you wait a week and you treat again. And parents also need to be combing through with a fine tooth comb every night. Lice is really, really hard work to get rid of. So parents, a lot of times I feel like they start combing, for the first couple days, and then they kind of give up on it because it's a lot of hard work, but the lice is going to come back if they do that. Okay. Scabies. So this is a mite that burrows under the skin and lays eggs, especially between the fingers. And what you see in the skin, I wish that there was a little better picture. I mean, this is very much what the scabies rash looks like. But a lot of times if you look really closely, you can almost see the feces kind of that's left in the rash. And then of course, because they're laying feces and eggs in your skin, it gets really irritated and your skin tries to fight it off, and that's when you get that red inflammation. Intense itching at night, especially. So kids with scabies or people with scabies, a lot of times they don't itch throughout the day. They may kind of have a little itch, but at night it's like they could rip their entire skin off. That's how much they're itching. Scabies, it's a parasite, of course, so it likes those dry, those moist, dark folds. So a lot of times, like between the buttocks, the groin folds, armpits, under breast tissue, and it's spread by personal contact with somebody else who has scabies. Permethrin, which is also what you use for head lice, because that's a parasite as well, is what you treat with. Okay. And everyone in the home, and if they've been in the car with a kid with scabies, I mean, everyone that's had any kind of contact with somebody with scabies needs treated. Okay. All right. Mother comes into the clinic with her 1-year-old who has visible infantile eczema on his face. She remarks she can't have his pictures taken because of the visible lesions and asks how long they will last or what she can do to get rid of them. What would be your response?
Keeping the baby's face clean and moisturized.
Mm-hmm. Using the ointments and stuff, right? That's important. Yeah. Letting her know that as she uses those ointments, it will improve. It's not going to be like that forever. Okay. But sometimes if their eczema is just kind of continued to exist and worsen, and it's not treated, sometimes there can be scarring. Okay. So I usually tell parents that the quicker you treat it, the less likely it is to scar. Okay. And you could also tell parents too, like, did she have something new to eat that she hadn't had before? Maybe that's what's causing some of the eczema. All right, there's more objectives. All right, burn injuries. This is the #1 cause of death between the ages of 1 and 4. Sometimes it's from child abuse. Sometimes it's from neglect. Kids not having supervision, and they have access then to, something that can burn them. The oven, they're in the kitchen. They're not being supervised. They open the oven up and burn themselves. I mean, kids can pull hot skillet pans on themselves too. And it doesn't always mean that just because that kid has a burn that's abuse or neglect, but that's oftentimes a form of abuse or neglect. So we have to be really cautious as healthcare providers on that. There's different types of burns. Thermal burns, which is going to be from fire, from scalding hot vapor or liquid. Chemical burns, those are going to be to a substance, so a powder or a liquid that kiddo comes in contact with, and it chemically burns their hand. But there wasn't a fire in that scenario. It was just that exposure to that chemical. Electrical burns, of course, that's from electricity. So that kiddo poked a knife into the outlet and got an electrical burn on his hand because of that. And then, of course, radiation burns. So if people are undergoing radiation for cancer, a lot of times that area that has the radiation, they'll get the radiation burn in that area. It can also happen from x-rays, potentially. So when looking at burns and trying to decide how severe they are, this is a good chart that tells you. So if kids have a burn to their trunk, that's going to be a higher area of their body surface area. So that's going to be a more problematic burn. Does that make sense? So the more surface area that's involved, the worse the burn is going to be. Or the higher the classification of the burn is going to be. Okay. Does that make sense? Okay. So here's some estimations of the amount of body surface area that are affected on different types of burns based on different areas. So I'll let you guys look at that, and based on age. So burns can involve just the skin or mucous membranes. It can, go through multiple skin layers. If burned near the face, I mean, it's likely that they inhaled flames, especially if it wasn't a chemical burn of the face. But if it's a chemical burn of the face, it's likely that they inhaled that chemical irritant as well. So a lot of times one of your biggest priorities, if there's burns to the face, that's going to be airway or neck. Okay. Face, neck, upper chest, airway is what you're going to worry about in those kids. So skin is thinner after it's been burnt, of course, because of the depth of the exposure of burn. It can be more serious if it's a really deep burn. So these kids are going to need moisture in those areas. So they're, a lot of times you can see in this picture, a lot of times they're going to have wraps, like a lot of moisture, a lot of skincare kind of things underneath, and then they'll have it all wrapped up. They're going to have increased basal metabolic needs. So they're going to need more protein and more calories to help with healing. These kids are going to have a huge loss of fluid and electrolytes and heat loss. So they're going to need fluid resuscitation, aggressive fluid resuscitation. Sometimes if it's a younger kid that's burned and they have pretty extensive burns over most of their body, then it's not uncommon for those kids to go into hypotensive shock, right? Because of that change in the needs of the electrolytes. And then potentially that shock can eventually lead to heart failure. Smaller muscles and fat content on the body, that increases the protein and caloric deficits as well. So making sure that they're eating plenty of protein and calories. So skin is more elastic after a burn. So what can happen is if you're pulling on that scarring area, so like, that kiddo has burns all over their body, they can't really reposition, but you go and you try and pull on the, that kiddo's, I don't know, the back of their shirt or something to move them, which you shouldn't be doing. But if you do that, then what's going to happen is that's going to pull on the skin, that's scarring, and it's going to cause a larger scar to form. Okay. And you don't want to have tons and tons and tons of people in the room with a kiddo who has had extensive burns, because of the risk of infection is so high. Okay. Sunburn, this is really common. It can blister. There can be partial thickness burn. Obviously stop the sun exposure, making sure that kids are wearing SPF blocking sunscreen. Zinc oxide is one of the most effective forms of sunscreen. So all of those natural sunscreens that you see now, like Blue Lizard and, oh gosh, I don't know why I can't think of them right now. Baby Ganix, I think, is a brand. Those are mostly just zinc oxide. So that's one of the most effective forms of sunblock is zinc oxide, and they don't have the added preservatives and chemicals too. So if somebody asks you for a natural sunscreen, then you could tell them get something with zinc oxide. Okay. Obviously, eyes can be burnt from sun exposure too, so sunglasses. Making sure to rehydrate the skin with something like aloe vera, something like that after the fact. And then, of course, like I said, sunscreen. And if there's a lot of inflammation, then the inflammation may need to be treated with a steroid or something like that. Okay. Frostbite, this is what happens from, extreme cold exposures. You can see the loss of the circulation to these areas because of the frostbite. And sensation a lot of times is lost in that area as well. And that can eventually lead to necrosis and then amputation if it continues. Okay. At Chiliband, that's the cold injury with erythema and the formation of the vessels. That then causes vasoconstriction, which is why you get that darkened color because of the loss of the circulation to that area because of the severe vasoconstriction that happens in really cold temperatures. So obviously kids with frostbite, or to reduce frostbite, is, gloves, wearing the appropriate winter gear outside, also not being outside for long periods of time if it's really cold. Okay. All right, here's your critical thinking question. The school nurse for an elementary school must prepare an educational program for school children on emergency responses for a burn injury. How would the nurse educate children on this process? So what kind of things can you teach kids about burns? Or how to prevent burns, right?
Make sure they're wearing sunscreen.
Yep.
If you're gonna cover it with a moist cloth, nothing dry.
Uh-huh. Yep. Yep. How about not touching hot things, right? Not pulling hot liquids, like cooking by themselves with oils and things like that. That's a lot of times can be like, as kids get older, they're wanting to cook by themselves, or cook for themselves. I had a couple of kids that I saw that had like grease burns. They were working in like fast food restaurants, and the grease had spilt on their legs and their feet. So things like that. The other thing too is if a burn is happening and that kid had like pants on or sweatpants on, when a burn happens, that material is going to essentially stick to that burn. So like just be cautious about that. Like if you're seeing a kiddo in the clinic or the hospital or something, and they have that burn in that area, and that material is going to stick to them. So if you're taking their pants off or something to assess the burn, it's going to peel more of that skin off with it. So just be careful. A lot of times what ends up happening then is it's just cut with scissors and removed that way. Okay. And removed with like added moisture, like moisturizing that area, and then kind of as you're cleaning the burn, peeling those pieces of fabric out. Okay. Okay. Child with metabolic condition. You guys can read these. So the endocrine system, this is functions from two different systems. So the endocrine system and also the nervous system, they work together. The endocrine system is ductless glands that regulate the body's metabolic system. So things like the thyroid, the parathyroid, the pancreas, the adrenal glands, the ovaries, the testes, pineal glands, hypothalamus, pituitary. Those are all involved in the endocrine system, but they all also work with the neurologic system for management. Okay. So some clinical signs that there might be something going on with kids' endocrine system is lethargy, poor feeding. All of a sudden, they're not eating as well. They're not gaining weight. They're not growing. Their height is dropping off their height curve or their growth curve. They may start having developmental delays or an odor of their breath or their urine, or episodes of vomiting, kind of with an unknown cause. Okay. A lot of times studies that are done is x-rays, but mostly blood tests. Okay. So there's different deficiencies. So this is talking about Tay-Sachs disease. So this is an autosomal recessive trait, most commonly found in Ashkenazi Jews population. So these are going to be lipid deposit accumulations on the nerve cells, causing physical and mental deterioration. So these kids start as normal infants until about 6 months of age, and then all of a sudden they start having head lag. They can no longer sit. They start having physical development deficits, and then it progresses to mental retardation, blindness. And kids with Tay-Sachs, they die almost always due to malnutrition or a secondary infection before the age of 5. There's no treatment for this. It's palliative care, so keeping them comfortable. And on genetics testing, it can identify if people are carriers in the first trimester. A lot of times that genetic testing is done. Okay. Hypothyroidism. So this is a deficiency in the hormones of the thyroid gland. It's one of the most common endocrine disorders. So the thyroid helps control the metabolism in the body. So if you're low thyroid, then it's not functioning appropriately. So low thyroid is essentially hypothyroidism or Hashimoto's thyroiditis. That's actually an autoimmune form of low thyroid. It can happen like from birth with some kids, can be hypothyroid from birth, and then it can become acquired later in life. Usually you notice it during rapid growth periods. So you might notice it in kids who were growing fine as infants, and then all of a sudden they're eating just fine, but they're dropping off of their growth curve. Or, in kids that are a little bit older that are getting ready to go through puberty, all of a sudden they're dropping off their growth curve. They're not gaining weight as well. They're maybe having some heart palpitations or chest pain or things like that. Or they may have, anxiety or depression that starts as well. Constipation. So we already kind of talked about that with hypothyroidism. So treatment for hypothyroidism, they're going to need the thyroid hormone replacement, and they're going to need their hormone levels routinely checked. The therapy then reverses the symptoms, and then the child should return to normal and be able to function appropriately. Okay. The other thing too is if kids start having hair loss or their hair becomes really brittle, then I get concerned also about hypothyroidism. And if they're hypothyroid, they have to do hormone replacement lifelong. Okay. So if kids are on thyroid replacement and they come in and they have any of these symptoms like irritability, weight loss, sweating, rapid pulse rate, then that would tell you that they're getting too much thyroid hormone replacement. They're getting hyperthyroid now because you're giving them too much replacement. So if kids come in like that, that would be your clue that maybe they're getting a little bit too much thyroid hormone and they need it lessened. And then if they're getting too little, then they're going to have fatigue, sleepiness, they're going to have constipation, weight gain, all of that sort of thing. So you can educate parents on kind of keeping an eye on those things, and that can kind of help them indicate if they're still too low and needing more, or if they're getting too high on their thyroid replacement. Diabetes insipidus. Okay, so this is with the pituitary gland. It's an autosomal dominant hereditary pattern. So if one of your family member or one of your parents has it, you're going to get it. Or it can be acquired from something like a head injury. Okay. It results in decreased antidiuretic hormone or vasopressin. So then you are diuresing uncontrollably. Okay. So if you have less antidiuretic hormone, you are what? Are you peeing you're peeing all the time, right? Because you don't have the antidiuretic hormone to regulate things for you. Okay. Parathyroid, these are really good charts because it breaks down each, like if it's low, so if it's SIADH, which is hyperpituitarism, which is increased diuretic hormone, you have increased antidiuretic hormone, that means you're not going to urinate appropriately. Okay, so you're going to have fluid overload. Kids with diabetes insipidus, they're the opposite. They're going to have fluid deficits. It's kind of confusing because it's opposite of what you think, because you hear diuretic and you think they're going to be peeing all the time. Okay. Does that make sense? And diabetes insipidus is not like diabetes mellitus. Okay, not the same thing. Doesn't mean those kids need blood sugar checks and things. Okay. And then this goes into Cushing's disease, Addison's disease, which is the adrenal glands. So that's going to be with cortisol. If they have Cushing's disease, they're going to have high cortisol. If they have Addison's disease, they're going to have low cortisol. Okay. So you're either going to be removing those tumors and replacing those hormones if they have Cushing's, or if they have Addison's, you're going to be replacing the cortisol and aldosterone. Okay. So that chart breaks all of those down briefly for you. Okay, diabetes mellitus. This is probably one of the most common chronic symptom or syndromes. So these kids their bodies don't know how to properly utilize carbohydrates and how to break them down. It's diagnosed with a fasting blood sugar level of 126 after they haven't had any caloric intake for 8 hours. You can automatically diagnose diabetes with that. Their body's unable to use and store fats properly, and they have decreased protein synthesis. Okay. When blood glucose becomes dangerously high, then they get into DKA, where they're spilling glucose into their urine and they're diuresing. So they're urinating all the time. The other thing with DKA that you can see is foul smelling breath. Fruity, foul smelling breath. Okay. Okay, hang on. I have some chats here. So I mean, class is over at 11:30, but we didn't take our break, so you can leave whenever you need to, Rebecca.
Thank you. You guys have a great day.
Yep, you too. So eventually, if diabetes mellitus isn't addressed, it can progress to blindness, and you can have long-term complications related to having hyperglycemia. So kidney disease, that's when you get the neuropathies and amputations and things. Here are the classifications. You guys can read this, so I'm not going to read it to you. Type 1 means they're going to be on insulin for their whole life because their insulin does not, or their pancreas does not produce insulin appropriately. Okay. Type 2, they're not always on insulin. They can be on oral medicines, and sometimes if their obesity or reason why they have diabetes is corrected and improved by, you know, dietary changes and exercise, then they don't always have to stay on a diabetes medication. Manifestations of type 1 diabetes, your 3 Ps, polyuria, polydipsia, polyphagia. So they're eating all the time, they're drinking all the time, and they're peeing all the time. Also, they're going to be more lethargic and have weight loss and weakness. Also, another thing that you may see is frequent yeast infections can sometimes be a sign of diabetes, type 1 diabetes, just because of the high blood sugars being out of control predisposes you to yeast infections. Lab findings. So obviously you're going to have glucose in your urine or glucosuria. You're going to have high glucose in the blood. And then your protein stores in your body are going to be depleted. Okay. An increase in glucose intake worsens increased glucose levels in the blood. You're going to do random blood glucose level or fasting blood glucose level, or they'll do a glucose tolerance test, which is what you see with pregnant moms. Okay. And then A1C, of course. That's the average of the blood sugar over a 3-month period. We're just going to skip that one too, but you guys can look at those critical thinking questions by yourself. DKA, so diabetic ketoacidosis. This is diabetic coma. This may happen from a secondary infection or if the patient is not caring for their diabetes. And ketoacidosis happens because of the insulin deficiency. So you're going to see ketones in the urine, decrease CO2 levels in the blood and urine. They're going to have that fruity breath, nausea. They're going to a lot of times have an altered level of consciousness, and these symptoms can become or progress from mild to severe within a few hours to days. Management for diabetes, like I said, some people have to be on insulin, so making sure that they're precisely doing that and injecting it in the appropriate areas in that subcutaneous tissue, and not every time in the same spot, or they're going to get really scarred up tissue in that area. Allowing that kiddo to live as normal of a life as they can, and encouraging regular exercise and a well-balanced diet, even in the kids that are going to be on insulin for their whole lives. There's some nutritional management. So essentially, they're going to be on counting carbs a lot of times and watching their carb intake and trying to reduce their overall cholesterol levels and their blood glucose intake. Okay. Insulin administration. Obviously, it can be given through a pump as well. That's getting to be more common. And a child 7 or older can be taught to do their insulin themselves. Okay. And you're at a 90 or a 45 for injection. Mixing insulin, here's your steps, depending on if it's a cloudy or a clear insulin that you're giving. Okay. And then they have insulin pumps, like I said now. And they also have your glucose monitors that can be in your skin and continuously be doing that. And a lot of those glucose monitors, if they're continuous glucose monitors on your skin, they can also talk to your insulin pump. And based on your glucose level from your monitor, it can give you insulin, or you can decide, you know, okay, how much insulin do I need based on my level right now? So that all that electronic stuff is getting really beneficial to these kids. Insulin shock or hypoglycemia, this is going to happen when the glucose levels get really low. And so in this time period, like it can happen if kids have been exercising a lot, or if they haven't been eating, or if they take too much of their insulin, that can happen. And kids are more prone to having insulin shock than adults because of their demands on their body with growth and development. Okay. So when that happens, you're going to give them glucagon. If they're awake, you're going to try and see if they'll drink some orange juice for you, or a candy or something like that. But glucagon, if they're really severely hypoglycemic, that's what you're going to do, injectable. Okay. Or if they're not awake enough to drink. Samoji phenomenon, this is rebound hyperglycemia. So this is with patients who have chronic insulin use, and they have to have really high doses of insulin to help regulate their blood sugars. What happens is hypoglycemia happens at night, and then high glucose levels happen in the morning because of this phenomenon. And so kids may need less insulin and not more to improve this problem. Okay. And then there's also something called the dawn phenomena, which means that you wake early in the morning with high blood glucose, and you didn't have the low glucose before. So both of these are really common in kids, and they're more common in kids who are kind of unstable in managing their diabetes. Type 2 diabetes, usually obesity, low physical activity, and then lipid-rich diets, which then results in insulin resistance. So first step for most people with type 2 diabetes is weight management and exercise, beginning to exercise. And then a lot of times what can happen is hopefully then they don't progress to needing insulin or oral glucose or hypoglycemic medications. Okay. But that can happen if it's not managed. We'll skip this too. Okay, now here's a whole nother chapter, but we're done with class time and I have to do the exam lecture. So you guys make sure you look at this PowerPoint. It's going to have a lot of the information that you're going to need on there. Okay. Do you guys have any other questions? I'm sorry I couldn't get through it all. It's so much information. I know you guys all are thinking the same thing, considering you all had to read 4 chapters this week. Okay. Any other questions or anything that I can do for you guys? No? Okay, if you're gonna stay on for my exam review, I'm gonna log off in the session and then I'll come right back on, okay? Here in just the next 10 or 15 minutes. Okay. See you later.